Hi, I'm Gillian, and I'm going to be talking to you today about my KTP project on the creation of novel biosensors for the detection of biomarkers within urine. So first things first, introductions. So the company I've been working for are called iDE8. They are a small company which provide a consultancy service, giving business-to-business support. They work within the medical device industry and have expertise in quality systems, validation testing, developing devices for market, regulatory submissions, and clinical data analysis. They're based up in Inverness, and most of the people in the company have good experience in the diabetes sector, having worked in this area previously. So, why did iDE8 decide they need a KTP? Well, prior to the KTP, they were simply a consultancy firm, and they created none of their own products. They had a desire to change this and begin to develop products themselves. However, they had limited access to labs, and as they were a small company, there was a desire for more scientific expertise. And so this is where the university comes in. So the University of the Highlands and Islands spans a huge area of Scotland, as shown in this map here, making it quite a unique institution. The Biomedical Sciences Division, which is where this KTP sits, is based in Inverness. Although they are a small team, the biomedical sciences do fantastic research in a wide range of medical technologies and clinical conditions, such as cancers, schizophrenia, inflammatory diseases, and nanotechnology. They have a good knowledge of all things diabetes and have valuable knowledge of how to create and optimize assays. On top of this, they have plenty of labs to work in and have recently moved into some beautiful new facilities, as illustrated in these pictures. So you know about the company and the university, so the final part of the KTP partnership is the associate, me. So a quick background on me. One of the main reasons why this job was such a good fit for me is because I love the Highlands. I'm originally from Inverness, and the surrounding areas are so beautiful, it's hard to drag me away. I studied biomedical sciences at university and went on to do a lab-based research master's as well. So I'm a bit of an all-rounder and have had quite a number of different jobs. I don't shy away from learning new things, and most notably for this job, I've actually had 4 years experience in labs prior to starting the job, with the vast majority of that time spent in a medical devices startup company. This company worked on urinary tract infections. Because of this experience, I would say I'm pretty self-sufficient and work pretty independently without much need for supervisory help. So what were the aims of the KTP? The aims of the KTP were to use the previously obtained intellectual property of the business to create biosensors out of super-absorbent polymers. At first, the KTP was fully targeted towards diabetes. So in year 1, we would create a colour-based sensor for diabetes to use with urine. And then in year 2, an electrochemical-based sensor for blood. The license to use this patent and the techniques discovered in the KTP were then going to be licensed out to other companies. Due to changing business needs, however, there was a need to broaden the goals of the project so that it no longer focused simply on diabetes. Therefore, the project pivoted into a second colour-based sensor, this time for urinary tract infections. So this sensor would not only need to detect bacteria within urine, but also what the best antibiotic to treat the infection would be due to the ever-worrying antimicrobial resistance crisis. So a bit more of a background on the biosensors. Superabsorbent polymers are a very diverse material which can be used in a variety of settings, from buildings to healthcare, and most notably for this project, because of their highly absorbent nature, they are found in nappies, sanitary towels, and incontinence pads. For the initial diabetes colour sensor, this was particularly important as the sensor is to be inserted into nappies and incontinence pads. This is particularly useful for the demographic which might not always be able to articulate a problem. Type 1 diabetes could be quickly detected in infants, and type 2 could be detected and controlled easily in elderly patients. As they're already wearing the nappy pad, there's no additional steps required, no peeing on a dipstick or going to get blood taken. If the sensor detected diabetes, then the patient could go and get more tests. This makes for a much simpler and community-led approach. So, the urinary tract infections are one of the most common types of infection we get, second behind respiratory. They predominantly affect women, with around 30 to 50% of women having a UTI at some point in their life. And they are often recurrent, with 50% of people having another UTI within 12 months of the previous one. Despite this, diagnosing UTIs is still not easy. There are 2 options: the easy peeing on a dipstick, quick, cheap, but not very accurate, as it doesn't pick up all the bacteria and it doesn't tell you what the best antibiotic treatment would be. Or there's a full culture. This is accurate and gives all information on treatment required, but it's expensive and takes a very long time. Because of this, doctors and pharmacists are likely to blind prescribe antibiotics. This leads to an overprescription and worsening the effects of antibiotic resistance. So the sensor that we are planning on creating is a quick colour test, similar to that inexpensive dipstick, but one that picks up on all bacteria and will give an indication on the best antibiotic to prescribe. So with a bit better understanding of this, how did the project get on? Well, first to the diabetes sensor. So this sensor will detect glucose in urine, as high levels of glucose in urine indicate that glucose is not regulated in the body and so indicates diabetes. It's not a perfect measurement and you normally would require a blood measurement as well, but it is a good first indication. So the sensor needs to have a number of requirements. So firstly, and quite obviously, it needs to work in urine. There can't be something in the urine that has an unwanted side effect with and colours when there is no glucose. And it also needs to be able to be seen in urine, hence a bright, non-yellow colour. As it is going to be used with nappies and pads, it will be against skin, therefore it cannot be toxic. Next, a low concentration of glucose within urine is normal, and so the colour needs to happen at the correct threshold. And again, obviously, the components of the assay need to be compatible with the superabsorbent polymer. Finally, it needs to be stable. This nappy or pad might not be looked at for a number of hours, so the colour needs to stay for a number of hours. So here's the sensor we managed to come up with, where you can see here you've got glucose below the threshold added in and it's clear. A low glucose concentration is lighter blue colour and that high glucose concentration is a very dark blue colour. So this sensor is bright, it was stable after 6 hours, and it has a threshold, and it's compatible with both urine and the polymer. So a decent success, although we haven't managed to try it with a nappy or pad, unfortunately. And now for the urinary tract infection sensor. So this sensor is far more complex. On top of all the previously mentioned requirements for the diabetes glucose sensor, this sensor has a number of other requirements. So first of all, UTIs are not just caused by one species of bacteria, but by a huge range, as indicated here by this list. You don't need to be able to read it, it's just to show you an idea of how many there are. So this is difficult to get a colour sensor which works with all these different bacteria. In addition, UTIs are also far more variable in concentration. So whereas in glucose, the concentration has a very limited 1 log unit variation, bacteria concentration can vary between 4 to 5 log units, from a very small amount like this to masses and masses and masses like this. The sensor also has to be specific to bacteria. So there are many other cells within urine, epithelial cells, red blood cells, white blood cells, to name a few. We don't want the sensor to detect these instead. In addition, it would be good if the sensor were to work at room temperature, so no equipment is needed to heat the sample. This is a bit tricky though, because enzymes and bacteria both like to sit at a cosy 37 degrees C. And then, on top of all this, we need to think about testing the sensor with antibiotics. So this means that the sensor must only be able to pick up live bacteria. If antibiotics have killed the bacteria, this needs to be seen by a difference in colour. And then finally, there's the difficulty of what is resistance. So resistance to antibiotics can be very variable, as shown here by the different sizes of circle. It can vary from very, very resistant, that's these tiny, tiny little circles here, to slightly resistant, that's the slightly larger circles. Our detector needs to be able to group all these together as simply resistant. So a big task, and it is maybe not surprising that the result isn't perfect. So here is the assay here. The pink here shows that bacteria is present, the purpley blue colour shows there's no bacteria present. So the colour changes from purpley blue to pink. When antibiotics are added in, if the sensor remains purple, it means that the bacteria is sensitive to that antibiotic. If the sensor then turns pink, it means that the bacteria is resistant to that antibiotic here. So this sensor has been tested with healthy urine spiked with 8 different bacteria at various concentrations with pretty good results. And it has shown a difference between sensitive and resistant bacteria when antibiotics are added in, but it only really works at 37 degrees C. And the range of concentrations and the range of antibiotic sensitivities becomes a little bit confusing. However, it is definitely a very good prototype that we've come up with. So what have been the successes of the KTP? Well, throughout the whole project, our partnership has remained a close-knit team, perhaps because we were small in number. We have had good communication with casual weekly meetings, and there has been little awkwardness in sharing information between the two groups. I would say there is now a strong connection between the biomedical sciences team at UHI and iDE8. iDE8 have also been able to test ideas out much quicker in this project than they would have been able to without the KTP. They've been able to do lab testing with urine, bacteria, and a number of different assays, something they wouldn't have been able to do without the UHI labs. As they're at an early development stage, this has been really important as they've not wasted a lot of time on simply one idea, but have been able to test many. Another key success from UHI's perspective is the setup of a microbiology lab, which I used in the second year of the project with the UTI stuff. There are also now standard microbiology procedures in place, which I've trained others from the university in. This is very beneficial for them as they need microbiology for separate projects that hadn't got around to setting it up yet, and it now means that other people from the university can also do that microbiology. There have, however, been challenges with this project as well. Firstly, after about 6 months, iDE8 moved out of their permanent office and became home workers. It was hoped they would be able to find another office quite quickly and potentially a good lab space with that. However, this has not been the case. This has meant I haven't really been able to sit with the company throughout the KTP, which has had obvious detrimental effects. So in addition to this, as has been happening across the university sector, there have been redundancies within UHI. My 2 knowledge-based supervisors were made redundant near the start of my second year, and because the biomedical sciences team is already very small, there was no one that was really able to fill that gap of both supervisors. There were a number of months where this wasn't really looking the best for me. However, through a quirk in the uni system, we managed to find a way around this. On top of this, the biomedical sciences team has been targeted for redundancies again, and it's again people I work with which are affected, so not ideal. And finally, there was that dramatic pivot away from diabetes to urinary tract infections, which was quite tricky to navigate. It was a much more complex topic, and although I've been lucky to already have experience in this area in my previous lab work, experimentation has been more tricky, and there have been no real microbiology experts to discuss this problem with, both in our team and within our biomedical sciences group. But onto a more positive note. So the focus in the KTP on personal development is great. I've managed to do a whole range of different trainings, conferences, certifications because the money and the drive have been there to do it. It has been fantastic to have that, and I couldn't understate it as a huge benefit. I've enjoyed all the KTP focused events as well. It's a great way to get to know very different people with very different interests to you. So these were just a range of the things that I managed to do with the money. The one thing I would say is there's so much money, it's sometimes a little stressful to know what to do with, and I'd say that maybe that would be something to talk about as the project's being founded, is what are you going to do with this money, how are you going to spend it? So what's next for the project? Well, in the last couple of months that I have left, I'll be finishing off any experiments that have loose ends and any documentation that needs tidied up. And then finally, I will have a training session with iDE8 on what I've done and how I've done what I've done. But after that, the future is all a little uncertain. Unfortunately, currently, there is not enough funding to support me to stay on permanently at iDE8. Hopefully, they will be able to get some money and continue on with the project, potentially with me there, either with that UTI sensor or with something similar, but a little bit different. Unfortunately, the story is much the same at UHI as well, with a lack of funding. So unfortunately, for me, the future is very much not decided. It's something that I've found, unfortunately, time and time again, that living in the north of Scotland really does have its downsides sometimes. So sorry to end on that down note there, but thank you very much for listening. And do you have any questions?